اغلبنا بيفكر في الحول في خلال ريسيس ريسكت واكسترا اوكولار ماسل ميجرمنتس، لكن كتير قوي بيكون كلمه السر بره الموضوع، سواء كان سنسوري ايلمنت، بيولوجيكال ايلمنت، او اوربيتال ايلمنت. فالاوربيتال abnormalities account for a small proportion of patients with strabismus, and it's very important to recognize these disorders for several reasons. Either for the etiology, we can identify the treatment for addressing the strabismus surgery, or for putting the proper decision as regards the timing and proper decision for the strabismus. So we should be aware of orbital causes of strabismus that may end up with strabismus and strabismus surgery before addressing any decision for doing strabismus surgery. The most popular form of orbital myositis, which is the thyroid eye disease, which usually presents with proptosis, lid retraction, strabismus or not. Sometimes we have orbital fractures, either orbital floor fracture or medial root fractures. Sometimes we have iatrogenic acquired problems after idiopathic myositis, occurring in some patients presented with acquired Brown syndrome. And sometimes the orbits are normal, but the patient may present with facial asymmetry. Like in this patient, she underwent right exotropia surgery, but still she has facial asymmetry, which may account for some cosmetic problems for the patient. Another form of facial asymmetry would widen at the higher orbit on the right side other than the left side. Now she had a beautiful strabismus surgery and she presented after surgery with properly aligned eyes, but orbital anomalies may account for the bad cosmesis of the patients in both patients. So, how to assess extraocular muscle improvement or progression in a patient with orbital disease? First of all, as classic teaching, usually we consider the primary position of the eye, like exotropia, esotropia, hypertropia, torsional element. We should be aware of the primary presenting sign of strabismus associated with orbital disorder, having the proper measurement of the angle and measurement of the angle follow-up and the frequent follow-up visits of the patient to know how the patient is progressing. One of the most important signs usually we forget is going for assessment of the presence or absence of secondary angle, because many patients may present with primary angular deviation, and if we did modified Klippsky test for that patient, we'll have another different angle other than the presenting one, which represents a very, very common cause of incompetence strabismus, which may be neurological or organic restriction or malinnervation syndrome. So we should be aware all the time of secondary angle presence or absence. Then we have to follow up our patients of orbital problem presenting with strabismus surgery, like with the proper follow-up of the limitation of motility, like in thyroid eye disease, usually we present with limited elevation and abduction of the eye. So how can we consider measurement of the angle, limitation of the progression, having secondary angle or not? We can measure the limitation of motility simply by a simple ruler. This is one of the tools, or sometimes we can use that custom bone glasses with calibrated marks denoting the improvement of limitation if you are addressing any medical treatment for that patient, like in thyroid ophthalmopathy, if you are giving steroids or autoimmune medications that can improve the limitation of motility. Sometimes we have to report and document the limitation of motility using some acid charts, and it's not an old-fashioned, like Dr. Said said, a very good presentation about the imaging of extraocular muscles, or documenting them, having a document of improvement of limitation or not. Nowadays we have the new digital techniques of having a digital HESA screen and Harms band and a crystal binocular chart and digital binocular sensory testing. Now became very popular. It was most popular in Germany, but nowadays it became popular in more areas worldwide. So again, we can use these documentations for assessment of the improvement. If you did recession of a muscle in thyroid ophthalmopathy, or botulinum toxin injection, or you removed some adhesions or granulomas from the orbit to assess the improvement of the movement of the eye post-operatively. So, in thyroid ophthalmopathy, it's a special syndrome or special case in strabismus surgery, because most people are worried about the proper timing of doing the surgery, when we can do the surgery for a strabismus patient presenting due to orbital myositis of thyroid eye disease. And now we have the EGUGU, which is very, very known European group of great ophthalmopathy, telling the clinical activity score is out of 7. So we should wait till the patient went through the quiescent stage, quiet stage, score under 3. if he passed 3 months in the quiet stage, we can address the strabismus surgery if it's steady measurements of the primary angle and the limitation of motility according to the clinical activity scoring. Many other different paralytic and restrictive strabismus cases may coincide, and you are in hassle, is it restrictive or paralytic? So again, back to basic, we should take proper history of any trauma, any systemic diseases, any strabismus surgeries before examination and imaging. Like in such a patient presenting with monocular elevation deficiency in the right eye, simply is a congenital double elevator palsy, but it can mimic some cases of orbital fracture. If I take history from this lady, she will tell me she had a car accident a couple of months before presenting to me with this hypotropia and the limitation of elevation, the same picture like that girl, but the difference is she had history of trauma and it's an acquired form, so we have to go for imaging of the orbit to know whether the fracture of the orbit accounting for this presentation. In these cases, we have to know the difference between the anterior fractures and posterior fractures of the orbit, because the most common presentation of anterior fractures is usually with hypotropia of the eye and the pseudotosis with limitation of elevation. But one of the uncommon presentations of fractures of orbit is the posterior fracture, which usually present without deviation in the primary position, but sometimes present with lip retraction or hypertropia sometimes, because the posterior fracture may cause feather-like effect. It has the sheath of the muscle inside the fracture itself, inhibiting the inferior rectus from doing its action of inhibition. One of the idiopathic myositis causes is the young dentist presented to me with diplopia when she looks up, and by examination she had acquired the Brown syndrome. When I asked her about detailed history, she denied everything other than having some knee pain, but when we searched for that knee pain, she had some of autoimmune diseases. She had orbital myositis. It was proved by CT scanning, so she underwent injection of steroids intraorbital and improved a bit, but 6 months later she came with the same limitation of elevation and abduction, and the V pattern it's acquired Brown syndrome. This is a picture after removal of the tightness on the superior oblique and removing some, actually I didn't do anything with superior oblique itself, but I found many adhesions around the superior oblique after having these myositis. We have to differentiate monocular elevation deficiencies because of main 5 causes, which double elevator palsy, Brown syndrome, congenital thyroid syndrome, fracture orbit, thyroid eye disease. Most of the causes are restrictive, and one only paralytic form, which is double elevator palsy. So you have to know by force reduction test or absence or presence of Bell's phenomena, is it paralytic or restrictive before addressing the surgery. This patient was presented with right hypertrophy, lid retraction after doing aggressive orbital surgery of huge cavernous hemangioma, and he presented with this hypertrophy. And this is my patient after doing recession of the inferior rectus muscle 6 months after the surgery of the orbit, and he presented well regarding alignment, but still he has right lid retraction. My last patient, this patient was presented to me a couple of weeks ago. She has right over left, limitation of elevation of the left eye, which looks to the dominant eye. All directions of elevation are absent. She can't move her eyes up anymore. So before surgery, I have to assess the primary angle, degree of limitation, because my decision for sure, as you all will do, is recession of the inferior rectus, but the titration of the recession of the inferior rectus will be depending upon the primary angle of deviation, degree of limitation, force reduction test. And regarding the force reduction test, we have to tell very clear message, because the force reduction test should be done with proversion, with retroversion, and after recession, after incising the conjunctiva and after this insertion of the muscle, and comparing all these results of force reduction test, because you may have lax muscle but frozen orbital tissues. So before doing recession, you have to know what about the conjunctiva and the extraocular tissues. And finally, the muscle elasticity should be assessed intraoperative to know the titration of the inferior rectus. And if you are going to recess the inferior rectus more than 7 millimeters, you have to do nasal shift of the tendon to avoid occurrence of a pattern. This is my patient first day post-operative after doing only inferior rectus recession of 7 millimeters with recession of the conjunctiva and doing nasal shift on the inferior rectus tendon. Thank you very much.